very much, my dear Professor Luca Rasulic, for the invitation and also the Serbian Neurosurgical Society. I'm really glad to be here virtually with you, and I will try to tell you our experience in the management of spontaneous intracranial hemorrhage. And as you know, intracerebral hemorrhage, it's a very devastating disease. It accounts for many patients that are severely ill, and it has a very high mortality as well. And the most frequent locations of the hematomas, as you can see here, are we say the deep-seated hematomas, the putaminal and thalamic hematomas, and then we have the lobar hematomas, and finally infratentorial hematomas, not very frequent but devastating as well, brainstem hematomas and cerebellar hematomas. And the goals of my lecture will be, as you can see here, speak of the mechanism of injury. Why would we choose to operate those patients versus best medical treatment and experience and the literature? And then minimal invasive surgery for intracranial hemorrhage in our experience. And I will show you later some clinical scenarios like intraventricular hemorrhage and what is coming, the next steps. So, talking on the mechanisms of injury and intracerebral hemorrhage, there is a first phase when the blood gets into the brain with parenchyma dissection and direct trauma. Of course, this is the mechanism of stroke, and there is initial neurological deterioration and early growth of the hematoma. But there is a second phase that is the developing of perihematoma edema that can last up to 3 weeks and explains the delayed neurological deterioration and are some of the bases for early surgical treatment. But as I told you, for decades, the surgical treatment of intracerebral hemorrhage was a very controversial issue. And the first randomized trial that was published in the literature, as you can see here in 2003, was the first STITCH trial. And the STITCH showed that there was not any benefit, as you can see here in this table, from surgery versus best medical treatment. Even the trial was not very well done or well constructed. A few years later, the STITCH 2 trial, published in 2013, showed that early surgery was a little bit better in outcome for patients mainly with superficial or lobar hematomas, as you can see here on this table, this graph. So what about the deep-seated hematomas? Many trials has been developed and been done for many years, and we'll show you in the history. And this is just a meta-analysis published showing different papers with MIS surgery and its results. So what about minimal invasive approach? It's a new technique? No, it isn't. There's a history, like everything in medicine. We have to see what was done to understand what we are doing and what we are going to do in the future. So Buckland in 1978 began with Archimedes' proof to make a direct aspiration of the hematome. Kandel did the same thing, and Kaufman began with a mechanical aspiration with some conventional aspiration. But I want to stress that Mizuma in Japan in 1989 began with aspiration with the use, stereotactic aspiration with the use of urokinase, that was a fibrinolytic agent. This is the series, I'm sorry, that is in Spanish, of Nizuma with 155 putaminal hematomes, and with very nice, good result in many of those patients, and mainly the patients with very good neurological condition. We began, I had the chance to work with my friend at the late Yves Kerabel and Jean-Paul Nguyen in Paris in 1889 and 1890, and with this technique. And I began in 1994 in Buenos Aires to perform stereotactic aspiration under CT guidance, as you can see here. And this is a short series we did many years ago. These were the inclusion criteria, as you got deep-seated hematomas, patients with good neurological condition, no coagulation disturbances, more than 25 ml, and no vascular associated malformation and DDH. And we used a conventional stereotactic technique with the volumetric measure of the hematoma and the stereotactic planification of the entry point and the main volume of the hematoma. And then we put the Archimedes proof for aspiration of the clot. And the end point was achieved when equal or more than 70% of the volume of the hematoma was aspirated. I mean, if it was not possible, we inserted stereotactic guided catheter and began with urokinase 6,000 international units every 12 years until the same endpoint. We did at that time 29 patients. The age, the surgery was between 6 and 48 hours from stroke, the volume of the hematomas. And we achieved excellent or good results in more than 50% of the patients. Some examples, this is, as you can see, a putaminal hematoma, big hematoma, pre and post evacuation, and another in this case on the right, pre and post. But it was a long time ago, and may I say that in the last 15 years, what has changed, how we treat this patient is the MISTIE trial, the development of the MISTIE trial. And you can see here that what is the rationale of this trial is a stereotactic guided catheter placement and an RTPA or the blast installation in the clot. And this trial began in 2012. And this has three different stages or phases. And this is the design of the first and the second stage. The first stage with 60 patients, they compared minimally invasive stereotactic surgery with plus 0.3 milligrams of RTPA with another dose, 1 milligram RTPA versus endoscopic aspiration. And they found that this concentration of RTPA was the best and is better than endoscopic aspiration. So the second stage in 50 patients was to compare the best medical treatment with the medical arm versus the RTPA aspiration. The inclusion criteria, as you see here, are the patient from 18 years to 80. You have here the Glasgow coma scale and the volume of the hematoma, the symptoms, at least 12 hours before the diagnostic CT. We have to have an intention to start surgery within 48 hours from diagnostic CT. And the first RTPA dose can be given within 54 hours after the CT. What is important is just to see if there's not expansion of the hematoma, so we have to make always a new CT before surgery. Well, that's just to show you. And what is the surgical technique? It's at the surgical arm, of course. It's to insert a 14 French cannula, a catheter, under stereotactic guidance in the center of the clot, and then to aspirate the hematoma, then to insert a soft catheter. Afterwards, to see if with the CT, if the placement was appropriate in the central axis of the hematoma. And then we begin with thrombolytic therapy with TPA, with the cycles of every 8 hours till the end point, that is a reduction of the clot 80% of, or to the clot, the volume less than 15 ml. It's important to do in all of our patients. We do an angio CT scan just to see if there's not any malformation. And these are the first results of the MISTIEs, the 1 and the 2, the second phase. This is the baseline demographic characteristic. Just to show you, this is interesting. The time to the operative procedure and to the first dose, as I told you, is less than 48 hours. And this is the presentation of the patients. This is the volume. See that, look that most of the patients with the surgical arm, they have a higher volume. And most of the patients, there are deep-seated hematomas. What is important, of course, we will see later on the results, that if we compare the estimated clot reduction of the medical group versus the RTPA dose group, of course, the patients that went through surgery, they have a clot reduction that is absolutely more fast. As I told you, what interesting point is the good placement of the catheter. And this has to be in the central axis of the catheter. We do in all our cases a stereotactic reconstruction to see if we are well placed. And this is the surgical performance of the surgeons. And this paper that was published just to see the surgical performance, comparing with the functional outcome. And it's absolutely clear, as it shows in this graph, that the better, the most experienced is the surgeon, the best is the target, and the best is also the functional outcome or the benefit. These are the results of the MISTIE phase 2, just to show that it's a safe procedure. And the conclusions that it's better in terms of cost, short hospitalization, and independent function for the patients. And finally, this is the results of the final phase, that is the MISTIE 3, that showed that patients with this procedure, MIS and thrombolytic therapy, they have less complications, and they have, of course, as I told you, the end of the treatment is absolutely it's fastest. And what is important is when we measure the ranking scale, the patients really, they do better than the medical arm. Again, you can see here the day 180, the modified ranking scale, and it's the surgical arm patients, they do better. So just in summary, we have more adverse effects in the medical treated group. We have a lower mortality in the surgical group, and patients with final volume less than 15 ml had a 10.5% difference of good clinical outcome over medical group. And each 1 milliliter of reduction of volume under 15 ml increased 10% the chance for a good clinical outcome. So we designed the same protocol. This is the protocol of my institution here in Buenos Aires. Our experience is 17 patients, 10 women, 7 men. This is the age. The mean Glasgow Coma scale was 13. 11 were deep-seated, 6 were superficial. This was some data. What is important that the mean time from stroke to surgery was 18 hours, and the mean surgical time was 75 minutes. And the first RTPA dose was at 6 hours from surgery, and the mean total dose was 4 milligrams for 4 doses. And it's really important that 6 patients returned home and 9 patients left hospital to rehabilitation, and 2 patients died. Just to show you 2 cases, this is a woman, 45 years old. She made a stroke, an aphasia, and right hemiplegia. This is a CT scan with the left thalamo-lenticular spontaneous intracranial hemorrhage. The patient was with aphasia, awake, was awake, answering questions with the right hemiplegia. And this is a CT scan, as you can see here, with this hematoma. This is 6 hours after surgery. We put the catheter in the main axis of the hematoma, as you can see here, the axial and the coronal view of the CT scan, and we made 1 milligram of Alteplas of RTPA. This is 48 hours after surgery with 3 milligrams Alteplas, 3 doses. We reached the endpoint soon after the 3rd dose, so we decided to take out the catheter. And the patient, this is the outcome, 7 days after surgery with the MISTIE protocol. She was doing really good with the Glasgow Coma scale of 15/15, right hemiparesia 4/5, and she was dismissed to continue rehabilitation at home. This is the patient. I have a short video, but it's a patient walking. This is another case, a 34 years old young woman. She came to our institution 1 week after a normal delivery with severe vaginal hemorrhage, and then afterwards sudden headache and stroke. Again with aphasia and right hemiplegia. Very similar hematoma. And again, we put the catheter. We began with thrombolytic therapy, and this is 72 hours after surgery with 4 milligrams of Alteplas, 4 doses, with a reduction of more than 80% of the clot. That it's our endpoint, I told you. So the outcome was 6 days after surgery. She's doing better, and with a 2/5 right hemiparesia and aphasia. And 20 days after surgery, she was dismissed to continue rehabilitation at home. Some cases, just to show you, again, a lenticular left hematoma, again, another hematoma, pre and post. This is on the right, an hematoma, the pre and post surgery. And this is the way we do with our planification, with the neuronavigation and planification. As you can see, here is the center of the hematoma. We do with the normal CT scan, and then with the bone scan to see if we are really well placed. We see in the 3 different planes, of course, in coronal, sagittal, and axial. This is another case with a lobar. This case is a lobar parietal hematoma. Another case with a lenticular right hematoma. The same case. And this is another lobar hematoma. And the positioning of and this is the way we do it in real time, taking the blood. This is stereotactic aspiration. Here again, some pictures. It's the way that we see that we are really well placed before the CT scan. Just some specific clinical scenarios. For example, getting out of the CT hematomas, the cerebral hematoma. Of course, still surgery. It's mandatory, conventional surgery, as you can see here, where there is compression of the brainstem. And of course, another clinical issue is enhancement of an hematoma, as this case you can see here. It was 60 cc and then was expanded 2 hours after to 72 cc. So it has to be operated conventionally. And the cases of supratentorial intracranial hemorrhage with imminent herniation, still surgery, it's an indication. And when there is evident herniation, of course, surgery, even the compressive craniectomy, it's an option. Just a few words on intraventricular hemorrhage. There is a trial that is the CLEAR. They also have 3 phases. This is the CLEAR that it's called to put a catheter intraventricularly and to instillate again RTPA. And these are the conclusions of the CLEAR phase 3, where what is important, if we achieve more than 80% of evacuation of the clot, intraventricular clot, there is a good correlation with clinical outcome with reduction of mortality. This is the baseline of, for example, of this, in this case is thalamic plus intraventricular hemorrhage. You can see here 1 milligram RTPA, 3 milligram RTPA, and the follow-up 20 days after. This is, of course, these patients, as all the patients with fibrinolytic therapy, they have to go through an angio-CT to see what if there's not any AVM or any vascular malformation. And this is another case, at our department with cerebellar, fourth ventricle hematomas. You can see here, and this is after RTPA with a very good outcome. So, in summary, as I have showed you, there are classic surgical indications for cerebellar hematomas, for herniated hematoma, even for lobar hematomas, but with neurological deterioration. But I do think that MIS and thrombolytic therapy is really a very, very good option for these patients. And just to end, to see what is next, what is coming. Of course, there are many trials. They are working on the different strategies to avoid clot expansion. As I will show you, by lowering arterial pressure and hemostatic agents. There are many trials as well, looking for different minimally invasive techniques. And there are also some pharmacological approaches in order to avoid the secondary brain injury and so to protect the brain. And finally, of course, optimizing rehab. These are the guidelines for the management of spontaneous intracerebral hemorrhage from the American Stroke Association. And well, they say something as I've been showing you. And this is a trial to do platelet transfusion. As I told you, this is a very interesting approach to the treatment of intracranial hemorrhage. And this is also another trial with intensive blood pressure lowering. And at the end, there are different techniques of minimal invasive approach to volume reduction. Of course, the thrombolytic evacuation is the one we are using. There is also ultrasonic assisted plus thrombolysis, endoscopic approaches, white matter sparing, mechanical clot lysis retrieval. So there are many different techniques that all of them try to avoid injuring an injured brain. That it's the patient with a spontaneous intracerebral hemorrhage, and try to reduce the volume of the clot as soon as possible. So thank you very much for your attention.